I would like to welcome you to our Wellness Masterclass with Dr. Nicola Finley. The topic is health disparities in Black and Brown communities. And I always like to give a little informal introduction to how I know fabulous people on our masterclass. And then Nancy Davis will give the formal introduction. So how did I meet you, Nicola? Well, it was Dr. Richard Carmona who introduced us. And most of you know Dr. Richard Carmona was 17th Surgeon General of the US, and he is on the board of the Global Wellness Institute. And we do a variety of initiatives, as some of you know, because many of you are involved. And we had a request from someone to start a new initiative on the topic of hormonal wellness. And it seemed like a great idea. I was starting to read more about it, and so I talked to Dr. Carmona, and he said, here's a person you need to speak with to learn more. And he said, you must talk to Nicola Finley at Canyon Ranch. So we spoke, and I learned a lot, not just only about hormonal wellness, but about some of the other very interesting things that she does there. And I found she's so down to earth and gets it about, she's a medical doctor, but she gets it about wellness. And as it turns out, we do now have a initiative on hormonal wellness that Nicola is part of, and I'm excited about that. But more formally, Nancy Davis, who is going to moderate this Wellness Masterclass, is going to give a more formal introduction. Nancy, and so
thank you, Susie. Thanks so much, Susie, and hello, everyone, and Nicola, thanks so much. Before I introduce Nicola formally, I'm just going to give you a few little logistical details on the Zoom calls, which we always do. Beatrice has muted everyone. With a group of this size and with the kinds of conversation, this eliminates background noise. Should you accidentally unmute, please mute yourself. But and you'll find that bottom left of your screen, there's a microphone, there's a red arrow through it and red line through it, and hopefully it will stay that way. If you want to see this glorious mosaic of faces from all over the world, on the top right, choose the gallery view. But when Nicola is presenting at the beginning of this session, I would urge you to use the speaker view. That brings Nicola more prominently on your screen. There are lots of people on the call and lots more joining. And if you want to scroll through pages of faces, the right center of your Zoom window, there's a blue arrow. And if you click that, you can scroll through the pages. There is a chat function. It's already, I see lots of people already posting, but bottom center of your Zoom window, there's a chat icon. That'll open a window to your right. And that's a great place, not just to say hello, and we love the hellos, but also to post a question. Susie and I both look at that throughout the call, and we try to grab those and aggregate those and bring them into the conversation. So please do that. I will just caution you that right next to the chat button, there is a bright green button that says share screen. Please don't hit that. That's very easy to accidentally hit. That's very distracting if all of a sudden your desktop shows up for everyone. And I do want to let everyone know, because the question gets asked a lot in the chat, this is being recorded, and the video of this call is going to be shared on our website. We usually do it within a day. So don't worry if you missed a few thoughts that you wanted to kind of jot down or remember. It's all recorded, and it's all for you and for you to share with your networks. Dr. Nicola Finley, a leading voice in health and wellness. At Canyon Ranch, Dr. Finley practices integrative medicine with an emphasis on prevention and wellness, which of course brings her to us. Prior to that, she worked for over 10 years with Tucson's economically disadvantaged communities at El Rio Community Health Center and St. Mary's Hospital in Tucson. She's also an adjunct faculty at the Melanina Zuckerman College of Public Health at the University of Arizona. Dr. Finley's areas of interest within the practice of medicine include an integrative approach to well-being, women's health, spirituality, and preventing chronic diseases. She's going to give us an overview of the health disparities in Black and Brown communities, and then take your questions. We're honored to have Dr. Nicola Finley here today as we continue to educate ourselves about the challenges facing communities of color with respect to health and wellness, and to also learn what we as a passionate, committed global industry can do to lead change. I'm happy to say we've become friends. So like Susie, I'll refer to Dr. Finley as Nicola. Thank you for spending time with us today, and over to you, Nicola.
Great. Thank you, Nancy. Thank you, Susie, for having me and for inviting me. I'm going to share my screen to, here it is, for my presentation. And here we go. Okay, just going to get myself set up.
Yeah,
okay,
perfect.
Oops, okay, hold on. Let me move this over. Okay. Hello, everyone. My name is Nicola, Dr. Finley. I'm excited to share this information with you. And we'll be discussing health disparities in Black and Brown communities. And I'll be speaking from my experience of working at El Rio Community Health Center and St. Mary's Hospital here in Tucson, which has a large percentage of Native Americans, specifically the Pascua Yaqui tribe, and Latino Americans, specifically Mexican Americans, as we're an hour from the Mexico border. And then I'll be ending the presentation about wellness, since everyone on this call has a passion for wellness, and I work at Canyon Ranch. So we'll be talking about wellness at the end and how wellness, I think, can fill in the gaps. Dr. Martin Luther King said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." So when we think about inequalities, we could think about inequalities in education, in our justice system, police brutality, in housing, and of course in healthcare. And I will be sharing evidence-based statistics that I think are shocking. And when we think about this being inhumane, the right for health is a human right. And so we'll be talking about health disparities in three communities: African American, Native American, and Latino communities. We could also carry the conversation about inequalities in the LGBTQ plus community, in rural white communities, in communities with disabilities, but today's conversation will focus in on ethnic minorities. So when we think about health disparities, I've listed here the definition from the CDC, the Center of Disease Controls, and it says health disparities is a particular type of health difference that is closely linked to economic, social, and environmental disadvantages. So specifically, really what we're talking about are worse health outcomes in socially disadvantaged ethnic groups. And these are due to structural inequalities. Another way we could think about health disparities is how it was described by Dr. Margaret Whitehead from the UK. She said health disparities are avoidable, unjust, and unnecessary. And I agree with that. So when we think about a person's health is more than a person's race or their ethnicity. It's also their socioeconomic class, it's their age, their geography, their education, their gender identity, their religion, their country of origin. So if we think about African Americans or Black Americans in America, there are differences, whether the person's country of origin is in the Caribbean or in Africa. If we think of the Latinx community, their country of origin could be Puerto Rico or Mexico or Central America or South America. So there are differences within groups. And when I worked at El Rio, I definitely saw health disparities in the communities that I cared for, which would be the Native American and the Latino communities. One of the health disparities that I saw dealt with diabetes. Brown and Black communities have a higher burden of chronic diseases, diabetes being one of them, but also heart disease, cancer, infant mortality, asthma. So if we look at this slide, Native Americans are 3 times more likely to be diagnosed with diabetes. Blacks are 30% more likely to be diagnosed with diabetes. Latinos are 1.7 times more likely to be diagnosed with diabetes. So why do we care about this chronic disease of diabetes? Well, diabetes increases the risk of heart disease, cancer, and pregnancy-related deaths. And I'll be talking about those 3 things. And I definitely saw that when I worked at El Rio and St. Mary's Hospital. In my community there, what we saw was a lot of patients having diabetes and then complications of diabetes, more heart disease, having kidney disease, having leg amputations. So diabetes is important because when we think about health disparities, we know that diabetes and other chronic medical conditions increase the likelihood of health disparities. But really what I want to concentrate on is not just the chronic diseases, which I just talked about, but also the social determinants of health. The World Health Organization defines the social determinants of health as conditions in which people are born, grow, live, work, and age, and how these factors shape their health. And all of these factors influences a person's health. Dr. Carmona, who's how I got connected to Susie and to Nancy, on his last master class, talked about social determinants of health in terms of COVID-19, in terms of increase in deaths and increases in cases. But these social determinants of health also impact and cause other medical conditions like diabetes, obesity, heart disease, and cancer. And so if I think about my family and I think about my family's social determinants of health, my family's social determinants of health helps my overall health. So in our neighborhood, we're able to ride bicycles with my husband and I, with our 13-year-old daughter. We don't have to worry about crime, stray dogs in our neighborhood. My daughter can play softball at the local park. But what I saw when I worked in an underrepresented community at El Rio Community Health Center, my patients' social determinants of health took away from their well-being, took away from their health. So they did not live many of them did not live in communities that were safe. So it wasn't safe for them to exercise. They didn't have access to fresh fruits and vegetables. And those social determinants of health impacted their overall health. So if we look at this picture that's on the slide, I'm going to talk about each one in turn. So I'll start at the top with economics. The economics of a person impacts their health in terms of their income, in terms of their job, in terms of food. Like I mentioned, having access to high quality food. When communities, when you go into their supermarket, do they have lots of fruits and vegetables? Farmers markets. When we think about education, education is not just health literacy, but higher education. And we could also think about childhood education, early childhood education, being a predictor of someone's income. When we think about healthcare, healthcare is access to affordable healthcare, having health insurance, as well as having a good health insurance, because some of my patients at El Rio had health insurance, but they didn't have access to lots of providers that would accept their insurance. When we think about healthcare, we can think about providers, and providers may be having a bias, providers may be not being culturally competent, and we can think about good quality care in hospitals. When we think about social, we can think about someone's support system, we can think about stress, we can think about discrimination, we can think about racism and how that impacts one's health. And then lastly, if we think about environment, and that's what I was talking about earlier, environment is so important in terms of housing, whether someone lives in a crowded apartment, in terms of safety, in terms of transportation. And one terminology that I read about that I think is quite relevant is a person's zip code is a stronger predictor of health than their genetic code. So a person's neighborhood significantly impacts their health, and sometimes we don't think about that enough. So what I thought I would do is start by talking about cancer, then we'll talk about heart disease, then we'll talk about pregnancy. Let's start with African Americans. In terms of African Americans, I'll start with breast cancer. African American women are more likely to die from breast cancer, even though white American women are more likely to be diagnosed with breast cancer. In addition, Black women who are diagnosed with breast cancer are diagnosed at a younger age than white women. So what are some of the reasons for this? Well, for African American women at diagnosis, they're diagnosed with a more advanced stage of cancer. And when we have a more advanced stage of cancer, that increases the likelihood of death, unfortunately, because treatment is harder. African American women with breast cancer tend to have a more aggressive type of breast cancer. And also there's lack of access to high quality of care. And so that slide that I talked about before, those social determinants of health, impacts the breast cancer risk. Because when we think about breast cancer risk factors, poor nutrition is a risk factor for breast cancer, obesity is a risk factor for breast cancer, and so is less physical activity. So again, someone's neighborhood impacts those things. If a person doesn't have a safe neighborhood to exercise, doesn't have access to fruits and vegetables, we can see why that could lead to obesity and lead to a higher risk of breast cancer. We could also see parallels with African American men in terms of prostate cancer. Black men are 2.4 times more likely than white men to die of prostate cancer. Some of the reasons are similar to what I talked about with breast cancer: younger age of diagnosis, more aggressive tumor type, and also less likely to be treated by surgery. So then if I move down to the second bullet point, thinking about the Latino community, the Hispanics have a 25% lower incidence, so the lower number of cases, and a 30% lower mortality, so a lower death rate. But what's interesting is Latinos are diagnosed with cancer, it's at a more advanced stage of disease. But there are differences within the Latino community, specifically in terms of prostate cancer, in terms of Puerto Ricans in terms of breast cancer were 60% higher than those of US Hispanics, and prostate cancer in Puerto Rico was 44% higher than white Americans. And this is something that's near and dear to my heart. As a family, we volunteered in Puerto Rico after Hurricane Maria. And so it's sad to hear about statistic differences specifically for that community. And when we think about Native Americans, lung and colon cancer rates are higher in Native Americans. And what's interesting is that there's a higher prevalence of smoking in the Native American community. So maybe it's not surprising there's a higher incidence in terms of lung cancer. And I remember when I worked at El Rio, and here in Arizona, we have a large percentage of a Native American population. A number of my Native American patients smoked. And unfortunately, it was cheaper on the reservations to buy cigarettes. I think it wasn't taxed like it was at a local, 7-Eleven. So that's a structural inequality, unfortunately. So I thought I would then transition to heart disease. And many of us on this call are wellness providers or in the wellness space. So we know our lifestyle impacts someone's risk of heart disease in terms of smoking, in terms of exercise, in terms of nutrition, in terms of alcohol intake, but also the social determinants of health impacts heart disease as well. So if I start with Native Americans, cardiovascular disease is more likely to be fatal in Native Americans. And what we know in our Native American communities is that the age of death due to heart disease is younger among Native Americans. And the statistic is 36% of Native American heart disease deaths occur before the age of 65. In contrast, before the age of 65, cardiovascular deaths for white Americans is 15%. So in Native Americans, it's double. And we also know there are more risk factors in Native American youths in terms of risk factors for heart disease, in terms of obesity, in terms of diabetes. So now let's look at African Americans. Despite similar clinical presentations, Blacks with acute heart attacks are less likely to be referred for cardiac procedures compared to whites. So this really speaks to lower quality of care. So if we think of lower quality of care, we know when someone has a heart attack, what's the standard of care is, if appropriate, to refer them for a triple bypass surgery of the heart, to refer them for the angioplasty, which is where the stent gets placed and can open up, break the clot and can open up the arteries. And African Americans are less likely to be referred for those procedures. In addition, for heart failure, African Americans are less likely to be referred for heart transplants. And then if we think about our Latino community, Latinos have a lower cardiovascular disease mortality rates than white Americans, and it's a 10% less likely to have heart disease. But when we think about Latinos, again, we need to think about the subgroups. And what we know in terms of the subgroups, in terms of Puerto Ricans, the number of Puerto Ricans who smoke is 65% greater than Mexican Americans, for example. And Puerto Ricans have a higher case of cases of cancer as well as heart disease. And heart disease for all ethnicities is the #1 killer. So heart disease is so important. And now I want to turn to pregnancy. When we think about pregnancy, what I have on the screen, I have the statistics in terms of pregnancy-related death rates for the different ethnicities. So you can take a look at that and you'll see the striking differences. And what we know in terms of health disparities, as I mentioned earlier, are preventable. What the research shows us is 60% of pregnancy-related deaths are preventable. And so this is where I thought I would share some, I think, shocking statistics. Pregnancy-related deaths for African Americans and for Native American women who are older than 30 years of age is 4 to 5 times that of white women. And these disparities are the same across educational levels. Pregnancy-related deaths among Black women who've completed college or higher was 1.6 times that of white women with less than a high school diploma. And when we think about comparing apples to apples, among women with college education or higher, if we think about these pregnancy-related deaths, for African American women, it's 5 times higher than for their white counterparts. And so these statistics are especially meaningful to me because my cousin, who is also Black, almost died during her pregnancy. And what she went through could have been prevented. And she has college education, she goes to all of her doctor's appointments, she's an executive director of her organization, she has good insurance, but the healthcare system failed her. And that is something we need to correct. So when we think about these statistics that are on the screen, what are some of the reasons as to why we see such health disparities in terms of pregnancy? Well, in medicine, we say things are multifactorial. There are many factors that lead to these disparities. So poor quality of hospital care during their pregnancy and during the birth, that's one reason. Another reason is lack of access to good prenatal care. Another reason is that higher burden of chronic disease, what I talked about earlier, having diabetes, for example, or having high blood pressure can increase the likelihood of having complications. And another study that I looked at that I thought was very interesting, looked at stress and how stress can adversely impact someone's health, including pregnancy complications. And the statistic was that Native American women and African American women had the highest number of stressful events during the year before their birth. So those stressful events can impact those complications we talked about, and also having a lack of access to specialists when they're pregnant. So those are some of the things that we think about when we think about pregnancy-related health disparities. So I don't know if you noticed, but when I talked about heart disease, when I talked about cancer, when I talked about pregnancy, comparing the different ethnic groups, the Latino community didn't have as many health disparities as African Americans, as Native Americans. So this first bullet point is a statistic that Hispanics showed a 24% lower death rate than whites. And that is despite having more risk factors. So that's a paradox, and it's called the Hispanic paradox, because it's a contradiction as to why is that. So if we think about risk factors in the Hispanic community, of all ethnic groups, statistics show Hispanics are less likely to have healthcare insurance. In addition, when we think about risk factors, there are cultural barriers, specifically language barriers. There's lack of access to preventative care. In the Hispanic community, there's more diabetes as well, heart disease. So those risk factors you would think would decrease the likelihood, would increase the likelihood of these of mortality. But what we know is Latino Americans have a higher life expectancy than other ethnic groups. And what we think is the reason is because of a stronger social connections, so family. And I know this to be true for when I worked at El Rio, my patients definitely had a strong family support network. And I can remember specifically one patient who was an older Mexican-American woman who was in the ICU, who wasn't doing well, and I needed to have a family meeting with her family members to share what was going on with her condition. And their family was so large and so many people wanted to be at this very important family meeting that there wasn't a room big enough inside St. Mary's Hospital for us to have this meeting. So we had to have this meeting outside in the courtyard. So it's a good thing we have nice weather here in Tucson, and I was able to share the information with their family. So that's so important when we think about a strong social network buffering those risk factors. Second data point is looking at the data for Hispanics show that being born in the US and the length of time in the US is actually a detriment, and it increases poorer health outcomes. And so the longer, and this is probably relevant to any immigrant community, I would think here in the United States, immigrants can pick up habits of the community in which they live here in the United States, such as unhealthy diet, lack of exercise. So that increases the likelihood of diabetes, heart disease, and obesity. And then I talked about the health differences among Hispanics, and the country of origin is so important. So I've been talking about health disparities in the United States. I thought I would transition to talking about health disparities in other countries, since this is such a global network with the Global Wellness Institute and Global Wellness Summit. I pulled up some data from England. Ethnic minorities in England are more likely than white majority to have advanced stage of cancer at diagnosis. Again, that leads to higher mortality. And when I looked at the research, it was similar to what we talked about here in the US. Lower health literacy, language barriers, higher rates of diabetes. And in one study that I looked at, ethnic minorities in England felt that they didn't receive the same quality of care. And this is really interesting because healthcare in England is free of charge through the NHS. So it's not the idea of not having health insurance. And the second bullet point is I did a little bit of research looking at indigenous populations and how in 23 countries there was a lower life expectancy of greater than 1 year. And in some countries for indigent populations, the life expectancy was greater than 5 years. So I wanted to share those statistics to see some of the parallels across different countries. I really like talking about this slide, and this slide is talking about, well, what are we striving for? Are we striving for equality? No, we're not striving for equality, we're striving for equity. Because if you look at this slide, when we think about equality and we look at these bicycles at the top, having the same size bicycle for different people is not the answer. Versus the second half of the slide, looking at equity, different size bicycles for different people meet their needs better. In terms of healthcare, we need to tailor healthcare to meet the needs of the individual person. And so it's the idea of equity means one size does not fit all. And I think about clothing, like when I go to stores and I see the label that says one size fits all, that doesn't work. That doesn't make any sense to me. I think now they say one size fits most in terms of clothing. I don't agree with that either. And so this slide is kind of reflective of my family because my husband is really tall. He's 6'3", and so his bicycle is very big. He's a triathlete, so he likes a lightweight bicycle. I'm not a triathlete. I like comfortable bicycles, so my bicycle is smaller. My 13-year-old's bicycle is smaller. So it's really the idea of one size does not fit all. So in closing, I thought I would talk about wellness solutions. When we think about wellness, when we think about health disparities, there's so many factors that are needed. We need to improve good quality health care. We need to improve access to health care, remove bias. There's so many factors. But I thought I would talk about wellness since we are a wellness community. And I know I'm preaching to the choir because we already practice personalized medicine, but it's really that idea of shared decision-making with our clients or patients and the providers. As providers, we need to show respect for our patients, spend time with our patients. And that's what I noticed at El Rio. I didn't have a lot of time with my patients. So I had to really try to maximize my approach as well as communication. Communication is so important. I speak Spanish, so that helped when I worked at El Rio. And when we think about a person's culture, we need to get to know their culture, and that's the wellness approach. And I love the idea of thinking about generational wellness. So in my family, we exercise together. My daughter sees me doing my Zumba classes, as well as my husband doing his triathlons. And she, as a result, is exercising herself because we're modeling that good behavior. But I want to leave you with a last concept, and that's the concept of wellness villages. Probably many of us on this call would have wellness villages where they work and where they practice. I practice medicine at Canyon Ranch, and at Canyon Ranch, I see Canyon Ranch as a wellness village. It is an opportunity for our clients to take care of each other, to have a network of providers, to take care of them. I see it as an opportunity for us to have an integrative approach. I remember a few cases where a massage therapist or an esthetician doing a facial for clients found an abnormality that led to being skin cancer. And so when we work together as a wellness community, we can hopefully fill in those gaps that might exist in terms of health disparities. So Thank you so much for listening to this presentation in terms of health disparities. I think we can increase awareness so we're more mindful of health disparities. And again, the goal is to achieve equity. So thank you.
Nicola, thank you so much. That was really, really a terrific presentation, incredibly informative. We are a group that likes to see numbers and statistics and really understand an issue, which you have really communicated just beautifully. So thank you. There were a whole bunch of questions, and don't worry if you did not write down Nicola's contact information or email. We will send all of that along, and with your permission, we'll send along your slides as well, so that everybody can have that information. I have a few questions there. You mentioned the high mortality rate among Black women, even when they have education and access to healthcare. I think this might dovetail a little bit to about the role of providers, implicit bias. Could you talk a little bit about that for us?
Yeah, thanks for asking. It's such an important question. Implicit bias is something that's important for us to think about. It's fairly interesting because Michigan, just this year, the governor in Michigan mandated that physicians will have to do implicit bias training, and she mandated that because of the healthcare disparities with COVID-19. She had a task force that saw that there's so many disparities, as I mentioned earlier, and Dr. Carmona mentioned, what can we do to overcome those disparities? We need to work on implicit bias. So what is implicit bias? Implicit bias is when we have unintentional behaviors or unintentional consequences of our behaviors. So when I think about physicians, I think that there might be physicians on this call, and I want to do right by my colleagues who are healthcare providers. I don't believe physicians intend to discriminate against patients. I don't believe the hospital system intends to have discriminatory practices, but it's there. And so we need to be able to be aware of our biases and be able to correct them. And I think most physicians want to know if there's a bias. Most physicians want to be able to correct a bias. And I think one of the ways that we can think about correcting implicit bias is through a concept called cultural humility. Cultural humility means, as a healthcare provider, I look inward and I look at my own culture and I look at my own experiences and how can that shape how I can take care of a patient of a different culture. And that's different than cultural competency. And I remember I went to medical school in the 90s. And when I was in medical school, there was a lot of well, not a lot, there was one class, a training in cultural competency. And that is to teach behaviors or to teach attitudes and behaviors about culture. Humility means I'm looking inward. So how can we do that in terms of cultural humility? We can interact with different cultures. As Nancy and Susie know, I love to travel. And so we can do that through traveling, but we can also do that by reading. When I was in medical school, I read a book that was very influential in my approach to taking care of patients of different ethnicities. And the book is called The Spirit Catches You and You Fall Down by Anne Fadiman. And I don't know if anyone on the call has read it or is familiar with it. I read this book when I was in residency. So I read this book in the 1990s. It came out in 1998, I think. And I think it's still relevant. The book is about the Hmong population, specifically a Hmong family from Laos in California. And their daughter developed a very severe form of seizures. And in their mind, in their culture, in their tradition, the seizure disorder was a spiritual experience for their daughter. The spirit catches you and you fall down. But for physicians, they didn't see this as a spiritual experience. And as a result, there was a clash between the Hmong community as well as the doctors. So I reread that book this summer, and it was so interesting. Now that I've been in practice for 20 years, now I'm a mom, I live in Tucson. So it was a very interesting way to think about cultural humility. That could be one way to overcome bias, but it's such a complex topic.
You know, you touched on a whole bunch of topics within that topic. I wonder, you know, trust seems to be at the heart of a relationship, well, in most relationships, certainly, and very much so between doctors and patients, providers and, you know, clients. Could you talk a little bit about the issue of trust in the context of health disparities?
Yeah, thanks for asking that question. I fully agree. Trust is so important. And like you said, in any relationship, especially when you're sick, we want to be able to trust our providers. And in disadvantaged communities, communities of color, there is a mistrust of the healthcare system. And specifically in the African American community, I think it stems from the Tuskegee experiment, which was an unfortunate, terrible study that the US government did on African American men. And so if you want, I'll explain it a little bit, but if you Google CDC Tuskegee, you'll be able to find more details. It started in the 1930s. It lasted for too long, 40 years, where the US government wanted to see the natural history of syphilis, which is a sexually transmitted disease that can cause death, that can cause neurologic damage. And the US government wanted to see what happens when we withhold treatment in terms of syphilis. So even when penicillin was available, the doctors did not give African American men penicillin treatment. Men died. They passed syphilis on to their wives, who passed it on to their offspring in terms of during childbirth. And it really allowed, unfortunately, caused African Americans to think that if I participate in clinical trials in terms of looking at research for the future, maybe they're going to experiment on me. Maybe I don't want to go to my doctor because I don't trust what my doctor is going to do for me. So what are the ways we can, and that was in the 1930s to the 1970s. That was a while ago. But as communities of color, that history is important and we remember that. But how can we overcome those that unfortunate situation? First, talking about the Tuskegee experiment and being aware of it. But I think we also need to move forward in ways that we can build trust. We can build trust through getting to know different cultures, our communication style. And I think also workforce diversity is also important. I have a statistic, here it is. And I have a statistic in terms of active physicians here in America, statistics in terms of diversity from 2018. And this is from the Association of American Medical Colleges. In terms of ethnicity, in terms of active physicians, 56% identify as white, 17% identify as Asian, 5.8% identify as Hispanic, and only 5% identify as African American. So I think if we can increase diversity, because what we know is that by increasing diversity in the workforce, diverse physicians tend to work on inequalities, also tend to try to achieve equity in addition to white physicians as well.
Yes, startling kinds of statistics. They're very sobering, aren't they? I mean, understanding this topic is something else. You know, many people in our industry, for sure, are driven to their work by personal experience. It influences what they're, you know, really passionate about and what they're driven to do. Could you share with us, so we can get to know you a little bit more personally, can you share with us personal or professional experiences that may have shaped your interest in these important topics?
Thanks for asking. I'd be happy to. And, you know, when I think about, if I were to go back to that concept of cultural humility, I think it's important as doctors that we listen to our patient's story. And in integrative medicine, we say every patient has a story. And every patient has a cultural story. So my cultural story is my parents are from Jamaica, and the motto in Jamaica is out of many, one people. And I think that has shaped my view of the world. I grew up in South Florida. I went to medical school in DC. I went to college in Rhode Island at Brown University, and now I'm here in Tucson. So all of those experiences shape my view of the world, and it adds to my cultural story because culture is evolving. And that's what's really nice about thinking about cultural humility. It's always evolving. So if I think about for myself and my family, if I were to first go back to my cousin that I mentioned who had those pregnancy-related complications, what I think is the silver lining in all of this is now she leans on the wellness community. She gets massages on a regular basis. She is balancing more that work-life balance in terms of work. She is, she sees an acupuncturist as well. So that's one example how the wellness community can impact someone, and it impacted my family. And I'm very close to my cousin. Her son is my godson. So very, very close to her. So if I think about my immediate family, I can think about my daughter. So my daughter's 13 and she's great. But when she was born, she had neonatal jaundice. So neonatal jaundice is when there's a chemical or a substance in the body called bilirubin, and it was elevated for her. And that's not uncommon when babies are born to have an elevated bilirubin, so this neonatal jaundice. So she had this condition in the hospital. They treated her with phototherapy, which is the UV light hitting the skin to break down the bilirubin. So when the doctor came in, the pediatrician came in to discharge us from the hospital, I said to her, shouldn't we check that bilirubin level again since it was high before? And the doctor said, well, we gave your daughter the appropriate treatment. She got the UV light therapy. There's no need to recheck it. And I said, but how do you know that the bilirubin is not still elevated? And what she said was, you could look at a baby and look at their skin, and you can see the skin is not yellow, so the baby does not have jaundice. And I thought to myself, we're African American. We have darker skin. You can't look at my skin and see if it's yellow. And so I said, and the same for my daughter. And I said to her, well, we're African American, so I don't think that's going to work. And she kind of paused. She looked at me and she said, okay. And she checked the bilirubin level, and we left the hospital. And we got an urgent call a few hours later. My daughter's bilirubin was not just elevated, it had increased somehow. And they urgently sent us the phototherapy light at home, and we were able to prevent a complication. That complication for a severe case could be brain damage, but many babies with neonatal jaundice end up going back into the hospital because they failure to thrive and they have fatigue. So I share this story because I don't think the pediatrician who took care of us in the hospital, I don't think she was racist. I don't think she was discriminatory towards us. I think she just didn't apply healthcare in an individual way. It's that one size does not fit all. So the way she takes care of white babies, she applied to the way she would take care of my baby, but it doesn't work that way. So I think that cultural humility and awareness is so important. That's why I'm so passionate about this topic, and also what I experienced when I worked at El Rio. I, on a daily basis, saw the consequences of those social determinants of health. My patients not having transportation to see their specialists, my patients not having insurance, or not even just not having insurance. If they had insurance, they didn't have the money to pay for the copay, and that impacted the health that they received. And language barriers. So there were so many factors, and I think that shapes why I'm so passionate about this topic.
Well, we're glad you are, and we're glad that you're sharing that passion and educating all of us. Maybe we could take a little bit of a turn because you worked for years in the community center, and now you work at Canyon Ranch. Are you at Canyon Ranch? Is that a full-time? Do you still work in the community? And can you talk a little bit about your own pivot to a real wellness village, as you described it, the kinds of patients, clients you see there, how that has changed, you know, what you're doing in your medical profession?
Yes, definitely. I love to talk about my journey. So I worked at El Rio and St. Mary's Hospital for 13 years, and now I'm at Canyon Ranch, and this is my full-time employment. When I work at Canyon Ranch, I've been at Canyon Ranch for 8 years. I love working at Canyon Ranch. I love the idea of having an hour with each patient. It's unheard of for a physician to have an hour with each patient. So I'm able to look at an integrative approach. I'm able to look at a holistic approach, looking at the whole person, mind, body, spirit. Spirituality in medicine is what gives your life a sense of purpose, connection to self, connection to others. And if a client comes into my office with knee pain, I still talk about spirituality because I want to know, how does their knee pain impact their quality of life? How does their knee pain impact their sense of purpose, connections to others? And that journey that you talked about, how it stemmed from the fact that I saw so many chronic medical conditions when I worked in the community previously, and I wanted to do more. I knew that it was more than just writing prescriptions in terms of giving medications. I knew it was more than taking care of very sick patients in the hospital, in the ICU. I wanted to back up and look at prevention. I wanted to look at lifestyle. So I did the fellowship that Dr. Andrew Wild has at the University of Arizona, the Integrative Medicine Fellowship. And that fellowship was a 2-year fellowship where physicians can learn that integrative approach. Because in medical school, transparently, we really didn't concentrate on nutrition, on exercise, and the benefits of looking at the whole person. You know, I've been out of training, and I was in medical school in the 90s. So things have changed now, but there's still not enough emphasis on prevention, on lifestyle. So I did the fellowship, and then I switched to practicing integrative medicine, and that's what we do at Canyon Ranch. And I think it's wonderful thinking about that idea of wellness being so important. So I see patients and clients at Canyon Ranch who also are interested in wellness. The clients at Canyon Ranch are looking for a holistic view, so they want an integrative approach. So I work with our nutritionists, our acupuncturists, our massage therapists, our exercise physiologists, and we're looking at the whole person. And I think that allows for reaching a higher level of health as a result.
You know, it's one of those things where it's like doctors should have to spend some time in a community health center, in their communities, wherever they are all over the world, in order to really understand and bring, sounds like you bring to your work now what you learned there, the sensitivities you developed, the interest in people's stories and cultures, which is, you know, so important to people's health. Susie, you have a question, and then I have a couple wrap up at the end.
Thank you, Nancy, and thank you, Nicola. This was very enlightening. You know, you brought up working with the people at Canyon Ranch, and I think a lot of us on this call do work with people who are in the upper economic level, you know, the top 1%, top 5%, because Canyon Ranch is obviously, you know, pricey. And I'm just wondering if you have found any way that could maybe give us some direction or hope in how to deal with that group, because a lot of us do, that maybe there could be some filtering down so that it isn't just the elite that we are working with, but that maybe affecting what they're doing or helping them, that might also translate to wellness for all, because we're not, you know, all in, you know, center city centers. So any insight on that you could share with us?
Thanks, Susie. That's such an important point because I agree with you, that concept of wellness for all. And what I have found with my Canyon Ranch clients is that they're very philanthropic and they're very giving. And I think that if we increase awareness, I think it can trickle down as you described. You know, it's interesting, Susie, because, and I think I've shared this with Nancy as well, before this summer, I didn't really talk about this topic among mixed ethnic groups. I really only talked about this topic if an African American group asked me to give a presentation on health disparities, and I would. And so I've been giving this presentation for many years. But I think now there's a spotlight on racial inequalities. I think people are more aware of what's going on. And so now I think I'm happy that I am being asked to talk about this topic, not just with communities of color, but with everyone. I think we all want to do our part, and we all are shocked by some of the statistics that I mentioned, that in 2020, we still have these health disparities. So I think it starts with talking about it, which is what we're doing now. So thank you for giving me this opportunity, and increasing awareness so we can figure out in our own communities what we can do to help with wellness for all. So I'm so glad that you asked that question.
Thank you.
Thank you, Nicola. Thank you so much.
Yeah.
We have just really 2 minutes left, so I'm going to let you have the last word, Nicola. But I just want to say that tomorrow, for those of you who join our calls, tomorrow we have a call at 9:30 Eastern, same time, and it's on wellness tourism, and should be an incredibly interesting conversation. We've not touched on that. Our initiative at the Institute that leads that will be leading that conversation. Should be very fascinating. I hope you will all be there. And so many of you write to Susie and me and ask what you can do and how you can get involved or what you can do to help, because these calls have been so great. So I will also just say, feel free to donate everything on our Institute website. We'll send all of that in the follow-up, but we produce the research that really has guided and shaped this industry, and we could use your support. I will just ask Nicola what I've asked every masterclass guest, and you've got to have a very short answer, is what keeps you up at night these days, and what are you optimistic about?
What keeps me up at night would be these health disparities continuing. And I think about my daughter when she's ready to start a family and she's pregnant. I don't want her to go through what my cousin went through. That's what keeps me up at night. What makes me hopeful is seeing everyone on this call, being interested in this conversation. And I've been looking briefly at the chats below, and I can see people saying wellness for all. We need to humanize this. We need to think about cultural humility. And that's what makes me hopeful, because I think that people are interested in making a change.
Now we'll unmute so you can get a warm global round of applause, which you richly deserve. And I
thank you, Nicola.
So
wonderful.
much.
Thank you. Wonderful.
Thank you, Nicola.
Information.
Presentation,
Really,
Nicola.
really.
Thank you.
ये अभी मैंने बात
Bless you,
की
Nicola.
बोल रहे थे अपने मेल एड्रेस व्हाट्सएप कर दीजिए, उस पे मेल कर दीजिए.
Do you feel the love?
I do. It's like a hug.
Thank you.
I appreciate it.
Get it, doctor. That was a
Bless you.
wonderful
God bless
thing.
you.
Thank you.
And we will make sure to send Nicola's slides, and the recording will be up on our website. So there's lots of follow-up.